Right, hello everybody. As Adam mentioned, my name is Anna Bangiri. I am a radiotherapy physicist at Nottingham University Hospitals, and I specialized actually at treating patients with brain metastases using stereotactic radiosurgery. What I'm going to do today for you is I'm going to talk a little bit about the radiotherapy journey, and I'm going to try and match up the steps that the patient sees with what we do as well. There will be some gaps from the patient's perspective, and I just want to fill in those gaps really, and explain to you what we do in the background, why we do it, and how it all the reasoning behind it. If you have any questions, feel free to stop me partway through. I don't really mind. If you don't understand anything, or if you want me to explain something again, I'm more than happy to do so. And we can have a short discussion or a long discussion if you want as well at the end. I don't have that many slices, but I've got quite a bit of talking to do partway through each slice. So if we get started. So I'm just going to talk, like I said, about all the steps to irradiating your brain. If you've been a patient or if you're a carer of somebody who's had radiotherapy, you'll know that they have to come to Moldrim to have a mask fitted. The mask is made from this little white material here, shown on our little Lego patient. Then they'd go on to have a CT scan, and then that is when the patient leaves our department, and then the gap begins about they don't really know what is happening. So what is happening in the background while you're waiting before you can get called for your treatment is that the doctor does some outlining. I will explain all these steps in great detail afterwards. We create your treatment plan, and we do some quality assurance checks. Then we do some more checks, and then you come back for your treatment. So if we take each step, in the mold room, this is what happens. You're asked to lie down on a couch. This is a flat couch, so it's not really as comfortable as when you would have had maybe an MRI scan or a diagnostic CT. And the reason for that is that these are the kind of couches that we have on our radiotherapy treatment machines. So we need to make sure that you're going to be in the same position that you are for your treatment. You're in the mold room as well. And we use what we call a headboard, which is another attachment basically, to secure your position on the couch. And we write exactly how we've set you up so we can reproduce that day in and day out while you're having your treatment. We use a headrest just to make you comfortable, and then also a knee rest as well. We don't, because you're going to be lying on your back for quite a while, so we just want you not to have any back pain at the end of your treatment. And then we fit this thermoplastic mask over your head. Now, the thermoplastic mask is basically made from a piece of plastic that we just warm it up in a warm bath with water, and then it gets very flexible and stretchy. We place it over your head and your shoulders sometimes. And this is meant to keep you still. The plastic will harden as time goes by. It takes about 10 minutes for this to happen. And then it's there to keep you still. Now, the reason why we want to keep you still is because, especially in your brain, you have a lot of different organs that are very important. And we don't want to accidentally irradiate them, thus causing you problems, side effects later on. So what happens actually is this mask is meant to keep you in place, and that makes us be certain that every day you go to the same position as you were on your very first day. I hope everything is making sense so far, so I'm going to move on. And then you would go on to have your CT scan. So you are placed in the CT scanner in the same position as you were in mold room. And then we place small lead balls on your mask The reason why we do that is because we have lasers to help us put you in place. But unfortunately, when we do the CT scan, we can't see the lasers. So we place the little lead balls so that we can actually mark the position on your scan of the lasers, because then we need to use the lasers on the treatment room to put you in the same position again. So we need to have like a surrogate of that position. And then we scan your brain, and then we have the images. Now, this is what your brain looks like on a CT scan. The slice on the left-hand side is a slice coming down from the top of your head going down to the bottom. And I don't know, I hope you can see me. It kind of goes down vertically. And it shows, you can see at the front here, this is part of your nose, this is part of your mouth, and this is the back of your head. And we can very well see your brain inside. This is another slice, but going what we call axially. So going down this way, this is actually the level of this slice is at the top here, just above your eyes. This is kind of to orient you, because now we're going to go through the process of what happens exactly. So we'll just need to be aware of what you're looking at. So if we move on, now I hope you can kind of see this clearly. We've got a few steps before the doctor can actually start marking where your tumor is. Now, unfortunately, CTs are not really great for visualizing things, especially in your brain, because all the tissues look quite similar. We can do it with a diagnostic CT. However, we don't want to do this with a CT for your radiotherapy planning, because we are going to be giving you too much dose that is unnecessary. So what we do is we actually use an MRI scan that you will have already had. It has no radiation, and we can visualize perfectly the location of the tumor. So what we do is we take a CT, and we take the MR and we fuse them together. So we put one on top of the other. So here, what I've shown is that you can really see very well the outline of the tumor. Oh, sorry, went the wrong way. And there, what the doctor does is, where they can see very well the outline of the tumor, they come and they draw around the little structure here. So this, in your orange outline, is our tumor volume. But for example, this is a glioblastoma patient, and we know that glioblastomas are very infiltrative tumors. So they've got little tentacles that they kind of tend to spread out, and even they tend to spread out further away from what you can visually see. So what we do is we put a margin. We put the margin on, and that is what creates a little green outline out here. And we're quite certain that within this green structure now, we have encompassed as much of the tumor as we can, even the bits that we cannot see. And then we add another small little margin, that is the extra red outline here on the outside, to basically ensure that even if you make small movements, or while you're being treated, or for any small differences that we might have in the machine, we're still going to be hitting our target, and we're going to be giving you the optimal treatment that we need to be giving you. So this is on the MRI scan. This is all being done. And then we have the fusion. Oh, sorry, again, I'm pressing the wrong buttons here. Apologies for that. And then we have the fusion with a CT. So here, as you can see in the CT, you can't really see the tumor that well. So what we do is, once we fuse them, we copy the outlines that we've done from the MRI onto the CT. And then we end up with something like this, where you can see both the MRI and the CT with the structures overlaying one another, and you can make sure that you've outlined the right thing. And then this is how we do the tumor. Now, however, we need to outline also a lot of organs at risk. So for example, here, again, this is a slice of the brain that we see in the middle over here. This is a slice going through like this to your brain, if you can see me. So here you can see your eyes, your lenses, the optic nerves, the optic chiasma, and the brainstem. Now, these are all very important structures. Obviously, the eyes and your lenses you use to see. The optic nerves are the nerves that are taking actually the signals from your eyes and through the chiasma back to the rest of your brain, so you can actually create that picture that you can see. And the brainstem is also a very important structure, almost like your spinal cord, that takes all the nerves from around your brain into it and regulates things like your heart beating, your breathing. So it's a very, very important structure. As you can see from here, the red outline is the tumor, and the tumor is very, very close and is sometimes even overlapping with important structures, your brainstem, your chiasma here, and your optic nerves. So we need to be very, very careful about the treatment planning that we do. So, and this is an actual view of a treatment plan. So what we do here, if you remember our outlines before, we've got the red outline that is on the outside, and we're trying to get it covered as much as possible with the red color wash here. And of course, you can see that we're not really doing that much of a great job around where we've got our optic nerves and the chiasma. The brainstem is a little bit more resistant to radiation. So we can, for certain things, we can overlap the doses and it's all fine, but we are scooping the doses outside of your eyes, outside of your lenses as much as possible. And the reason why we do this is because obviously we want to kill the tumor, but we don't want to leave the patient with a lot of side effects. We do not want to leave them blind. We do not want to leave them deaf, with dry eyes. So we need to have this balancing act that we do, whereby we need to give as much dose to the tumor as possible so that we kill it, but as little dose as possible to the organs at risk so that the patient doesn't have side effects. As I mentioned, this is a bit of a balancing act, and it depends on the particulars that for each patient. So for example, the extent of the tumor, what kind of tumor it is, at what stage we're at, and also what is the patient willing to accept. This is a discussion that goes on in the background with the doctor and the patient, and then the doctor relays that information back to us, the physicists that would do the treatment planning. So that we know what we're aiming for, what we can achieve. And then once we have a plan ready, we give it back to our oncologist, and they say, actually, yes, this is great, or no, can you change a little bit this here and a little bit that there? Or maybe, this patient is not worried about losing their hearing on the left-hand side. I'm just saying a random example now. So I wanted to make sure that you are covering and treating all the tumor around that area. So we have to make constant decisions like that all the time when it comes to treatment planning. I'm gonna stop here for a second and ask you if you have any questions, or if there is anything that you would like me to repeat. I can't see you, so If somebody can say yes or no, that would be great.
I can't see any hands up or anything. If I guess if people did want to ask any questions throughout, they could put it in the chat if they'd rather wait till the end as well.
Okay, that's fine. So I'm going to carry on. So the next step, once the plan is ready, is we have to do some tests to ensure the quality of the treatment plan. There are multiple reasons why we do the tests. And actually, one of the reasons is that we use a lot of complicated software in the process of creating treatment plans and treating radiotherapy patients. And we have to move the plan from between different systems. And when you move things between different systems, there is always a potential for corruption. It has hardly ever happened. However, because it has happened in the past, we have put processes in place to make sure that if it does happen, we catch it and that it will have zero impact on our patients. So what we do is we deliver the treatment plan on a phantom, and it can be a phantom like the one that I've shown you here, or a phantom that is more looks like a human. We call them anthropomorphic phantoms, but basically it's just a phantom that has human anatomy inside. They've got bones, they've got different structures. And we just want to check that actually what we were planning to deliver and what we created in our treatment planning system is the same thing, the exact same thing that is being delivered to our patient on a day by day basis. So we check that no corruptions have happened, but also we check that the treatment that we created will be delivered exactly as we intended it. And there have been no problems with the treatment planning system itself. Um, so before the patient comes in for treatment, we actually get on the treatment machine, we put our phantom on, we do the delivery, and we compare the results of what we were expecting to get with what we have actually gotten. We match those up. And then if we're happy, only then we then go on to do some more tests. And after we do the tests, you can come in and have your treatment. In our hospital, we use. Sorry, did somebody say something?
No, I think
No.
it's just
Okay, that's fine. So in our hospital, we use this kind of equipment here on the left. But if you've been treated in a different hospital, your equipment might not look exactly the same. It just depends. And it depends where you get your treatment. It's just different providers really that we're having, that is all. And the whole room would look something like this, little Lego version of it. So the process that I explained is actually mostly for patients with primary brain tumors. And brain metastases are slightly different. Brain metastases, normally they have other treatment in 1 or 3 fractions instead of 30. And I'm only talking about using the type of treatment called stereotactic radiosurgery. You might have had brain metastases but had whole brain radiotherapy, at which point the process would be a lot more similar to what I've explained actually, and you would come in the hospital for more than 1 or 3 treatments. The brain metastases, you wouldn't have one large tumor like I've shown, but you would have a lot of smaller tumors, and they could be dotted around the brain anywhere. The plans look completely different, and you might be able to come for multiple treatments as well, spaced out over the year or 2 years or however long, potentially more. So this is a typical plan for brain metastases, where you can see that we have actually very small tumors, and we've got, in this case, we've got 3, 1, 2, and one at the top of the brain, here 3. This is a slice of a brain going from the top to the bottom, but kind of if you imagine it going through your shoulders rather than the other slicer that I talked to before. Yes, also the other thing that you can see is that the dose around the tumor is a lot smaller, a lot less. The reason for that is that metastases are very, very well defined. They're completely different from primary brain tumors in the sense that they're not infiltrative at all. So what we can see on the MRI scan is the end of the tumor. And we don't need to add this very, very large margin that we do for primary brain tumors because these kind of tumors don't have the little tentacles, they don't spread out. And because they don't spread out,
Right.
we can put a much smaller margin there. So this is it from the brain metastases point of view. And this is just to recap exactly why we can't use the same technique. As I mentioned, metastases are well defined. So the margin, that extra little outline that we use around would be 1 millimeter. But for example, a margin for a glioblastoma would be 25 millimeters. So a lot larger. The primary brain tumors are infiltrative, whereas brain metastases are not. And of course, the volume matters. We can only treat metastases that are less than 20 cc's, but a typical glioblastoma would be around 200 cc's. And this is why we can have this much, much tighter dose around them, just because the volume is so much smaller.